before we get started, let me go through a couple housekeeping topics. Today's session will be recorded. Everybody can visit our website, chcf.org/California Improvement Network. Both the recordings and the slides will be posted for download within a week. We'll be doing a question and answer session at the end. So if you have a question during the presentation, please go to the chat box and select chat to all participants so that everybody on the call can see your question. And if you have any administrative questions or logistical questions, feel free to chat to me, the host, and I will help you out with whatever technical issue you might be facing. And so today, let me introduce you to today's speakers. We have Dr. Alice Chen, the Chief Integration Officer, Director of the Center for Innovation in Access and Quality, and Director of the eReferral program at the San Francisco General Hospital. Dr. Chen's work focuses on creating policies and programs to improve access and quality of care for underserved communities. With Alice, we have Delphine Tout. Delphine is an assistant professor of medicine at the University of California's San Francisco Division of Nephrology at the San Francisco General Hospital. Dr. Tout's work focuses on the implementation and evaluation of interventions that increase patient awareness and self-management of kidney disease, as well as health system changes that improve kidney disease management. Today we also have Nwanjo Olewala, a family physician, the Associate Director of the Center for Excellence in Primary Care and Assistant Professor in the Department of Family and Community Medicine at California State University, San Francisco. Her research and policy interests include primary care redesign and transformation, patient-centered medical homes, their impact on access, quality, cost, and equity. Nicole Japil is a project director with the Community Health Center, Inc.'s Wiseman Quality Institute. As a project manager, she is responsible for the oversight and implementation of large regional eConsult programs. And lastly, we have Dr. Jeffrey Greenberg, an associate medical director at the Brigham and Women's Physicians Organization, medical director of the Standardized Clinical Assessment and Management Program at BWH, and instructor in medicine at Harvard Medical School. In these roles, he is responsible for engaging physicians in defining, measuring, and improving the value of care delivered. So we have a great group of folks here today, and with that, I will pass the ball over to Alice.
Great. Good afternoon. So this is Delphine speaking on behalf of my colleagues at the San Francisco Health Network. So for the first couple minutes, I would just like to give you a brief sense of our system here in San Francisco and a little bit more detail about eReferral, our electronic referral and consultation system. And then for the second half of our presentation, discuss a little bit more about the facilitators and barriers to implementation of this system. And after that, you'll hear from our colleagues in other locations across the U.S. who can delve down a little bit deeper and talk about details of their own systems. So here in San Francisco, the San Francisco Health Network is a vertically integrated safety net system for San Francisco's uninsured and underinsured patients. We have a core primary care population of a little over 120,000 patients. But more importantly, or equally importantly, we provide comprehensive ambulatory specialty and diagnostic services. And in 2012, 2013, you can see that those visits exceeded 330,000. We also provide behavioral health services, acute and trauma care, jails health services, and long-term care for these individuals. Now, we long recognized that, similar to other networks and other systems, the primary care specialty care interface is one that is not often patient-centered and is often inefficient. And circa 2005, our system, like many others, was paper-based or telephone and fax-based. And scheduling was based on first served, essentially, or first referred, first scheduled. And there were significant inefficiencies with the system. For example, many patients were referred to the wrong clinic. unnecessary referrals or premature referrals. Specialists were unable to discern the referral question, as you can see on the right-hand side of your slide, and there was a lack of equitable triage in terms of who was seen first in a specialty clinic. As a result, wait times were as high as 11 months in some of our specialty clinics. So with this in mind, a group of us here at the San Francisco General Hospital, led by Alice Chen and Hal Yi, developed an integrated electronic referral and consultation system, which we have named eReferral. So let me just spend 1 minute or two just to walk through the eReferral workflow. So in our system, a provider, often a primary care provider, but not always, submits an electronic referral to a specialist. That referral is reviewed electronically by the specialist. That includes the primary care provider's question and a little bit of history. And all the relevant clinical and laboratory data are appended to that referral from the electronic medical record. The specialist reviews that referral. If it's to the appropriate specialist and the pre-referral workup is complete, then the specialist can automatically send that referral to a scheduler who can schedule for the next available, so non-urgent appointment, or can overbook that patient for an urgent appointment. On the other hand, if the specialist reviewer thinks or believes that the consult question is unclear, or that the pre-referral workup is incomplete, or he or she can help guide the primary care provider electronically or virtually, then that patient is not scheduled and more information is requested. And there is an iterative conversation that goes back and forth between the primary care provider and the specialist. Now, oftentimes, when there's sufficient information or the pre-referral workup is complete, which we consider pre-consultative exchange between the primary care provider and the specialist, then the patient is eventually scheduled for a specialty clinic visit. Often, though, the primary care provider and the specialist collaboratively determine that the patient never actually needs to be seen in specialty care clinic, and this is what we consider virtual co-management of conditions in primary care. Now, importantly, the ability of a patient to be scheduled for a primary care visit or for a specialty care visit can happen at any time, so we really enforce the collaborative nature among primary care and specialty care providers. So to give you a sense, between July of 2011 and June of 2012, our system had over 27,000 new e-referrals just for specialty care. This excludes diagnostics, which add an additional 25,000 e-referrals. Of those, approximately 60% were considered appropriate and complete and were automatically scheduled immediately for a specialty clinic visit. Of the 40% that were not initially scheduled for a specialty visit, approximately half included pre-consultative exchange and were eventually scheduled, and approximately half were actually never scheduled for a specialty care visit. And this is where a lot of the savings occur within the system in terms of access to care, because these are specialty care appointments that are then opened, or slots that are then opened for patients who would benefit more greatly by a face-to-face specialty care visit. And as you can imagine, this system had a dramatic impact on our wait times to specialty care clinics in the San Francisco Health Network. Here we depict some data from the 5 first medical specialties that were onboarded to eReferral. Pre-eReferral, wait times for specialty clinic were around 6 months or sometimes greater, as high as 11 months, as I mentioned earlier. After eReferral, these wait times have significantly decreased and now have reached a stable 1 to 3 month time period. Still goes to show that we have room to improve, but a certain improvement. And importantly, primary care providers and specialty care providers are satisfied with the eReferral system. The data depicted here are data from some of our primary care providers in which we asked, overall, how has eReferral changed clinical care for your patients? And in the red bars, you see that overall, over 70% of primary care providers felt that eReferral improved clinical care for their patients. Approximately 20% said there was no difference, and a minority thought that eReferral worsened the care. What is interesting is that providers who were co-located with the specialty care providers at the San Francisco General Hospital, depicted in the darker purple bars, and those from our Department of Public Health run community clinics. So again, within the Department of Public Health, the medium purple bars, you see that those groups of primary care providers were more satisfied with eReferral. The primary care providers who refer to the San Francisco General Hospital for specialty expertise and for specialty advice, but are not associated or not integrated with the Department of Public Health network, those individuals were less satisfied overall, although still clearly a positive trend. And what is interesting is that with these satisfaction results, we keep trying to refine our system to continually improve. One of the areas where we noted some dissatisfaction with some responses from some of our specialists. And so one way to improve both the primary care and specialty care communication, we instituted bidirectional feedback where specialty providers rate primary care providers' consultation requests. They rate the reason for referral and whether it is an appropriate consult. And on the other hand, primary care providers rate specialty care providers on the helpfulness and educational value of their consults. We have given this feedback to specialty care providers and to primary care providers, and while I don't have those data to show you today, over time the quality of the consultation communication has certainly improved. Now, in light of this, there has been widespread interest in electronic referral and consultation systems. As many of you know, specialty care visits comprise over 50% of all ambulatory visits in the United States. And recent data suggest that on average, for every 100 Medicare patients that a primary care provider takes care of, he or she needs to interact with 99 other providers in 53 different practices. Lack of timely specialty care can result in adverse outcomes, unnecessary emergency department visits and hospitalizations, and potentially higher healthcare costs. So with this lens, numerous organizations have reached out to the San Francisco General Hospital to get a better understanding of our eReferral system and how we implemented it. Now, eReferral or any type of electronic referral and consultation system is disruptive to the traditional way in which specialty care is delivered. And so to better understand what other groups have done since they've reached out to us and to understand best practices, we interviewed a variety of healthcare organizations to see how they have implemented their eReferral programs. We wanted to understand the drivers to implementation, facilitators and barriers to eCR implementation, and best practices. Our study participants included a wide range of systems that included academic medical centers, SFGH networks, nonprofit organizations with volunteer subspecialists, health plans, as well as private systems. And while you can see we have great representation from California, we also have some representation across the United States and an international presence as well. And importantly, these were all individuals who had reached out to us initially to better understand how eReferral came about and how it was implemented. Now, before I delve into some of these results, I just wanted to take a minute and describe our definitions of what we consider an electronic referral system and an electronic consult system, because the drivers of each of these elements are slightly different. So we define an electronic referral system as one in which a primary care provider or any provider poses a question or a referral to a specialty care provider with the expectation that the patient will be seen in specialty care clinic. On the other hand, electronic consult has a similar question, but does not carry the expectation that a patient will be seen in specialty care clinic. Now, it's important to note that most of the organizations, or many of the organizations with whom we consulted or with whom we discussed in these interviews, had elements of both eReferral and eConsult systems. And importantly, the integration of the two in one system allows seamless use by the end provider. So now going back to the drivers of implementation, drivers of electronic referral systems were mainly to enhance efficiency, to to enhance clinical efficiency, i.e. more equitable triage, more readable or legible communication between providers, and to provide a more efficient first visit in specialty care, and to enhance operational efficiency, which largely meant tracking by primary care providers of their referrals. eConsult systems, on the other hand, were largely implemented to improve access to specialty care, really trying to level the supply-demand mismatch of specialty expertise. They also were implemented to improve the delivery of coordinated specialty care and to decrease patient leakage to other delivery systems, i.e. to improve patient retention. Facilitators to implementation, not surprisingly, included engaged leadership, which included executives as well as clinician leaders who were often early adopters of the technology and of the system. Other facilitators included strong partnerships with stakeholders and user-friendly technology that were integrated into clinician workflows, reimbursement mechanisms for clinicians, as well as dedicated program staff for outreach and marketing. And importantly, that the system was designed to respond to the organizational challenges, really respond to the drivers that I mentioned earlier. Barriers included clinician resistance to change. In many of these systems, the workload for the primary care provider increases, as well as the workflow for the primary care provider changes, and oftentimes the resistance to change made it difficult to implement. These systems also enhance or increase specialist workload as they have to review many of these or most of these consult requests. Lack of integration with the electronic medical record was a barrier that was often identified, although was surmounted by a number of systems. And inadequate funding for the vendor platform and ongoing vendor support, as well as funding for specialist compensation for the time that they spent reviewing referrals. And specialists from a variety of different systems voiced concerns with liability. So in summary, we just want to highlight that the elements of successful implementation of electronic referral and consultation systems are essentially systems that meet the organizational needs, that meet the drivers, as well as include executive leadership, clinician leadership and early adopters, and include efficient workflows for all providers, primary care providers as well as specialty care providers. Having funding and payment models set or already thought of or developed before implementation is clearly important. And integration with an existing EMR or existing technologies is important as well. So with that, I'd just like to acknowledge our eReferral team here at the San Francisco General Hospital and at the Center for Innovation and Access and Quality. We have numerous other materials available about our implementation. It includes the results that we have presented here, as well as more in-depth discussion on the CIAC website, which is at www.ciacsf.org, or you can find it if you just Google eReferral and UCSF. And with that, I'd like to thank many of the organizations that helped us put this work together over the years. And I think I will pass along the baton to Wando, who will provide additional information.
Great. Thank you so much, Delphine and Alice. Good afternoon, everybody. It's a pleasure to be able to speak with you about the work that I have been part of at Community Health Center, Inc., which is a large, fairly qualified health center in Middletown, Connecticut. And I'm going to be collaborating with Nicole Japil, who's the program manager for the eConsult program. I really appreciate Delphine's laying out the differences between eReferral and eConsult. And we will be focusing more on an eConsult model that was developed and continues to expand at Community Health Center, Inc. So I won't rehash some of the challenges that led the organization to developing this kind of program, but I will talk a little bit about the organization and some of the structural challenges that we faced. So Community Health Center, Inc. is Connecticut's largest federally qualified health center, as I mentioned. It has 13 primary care sites throughout the state of Connecticut in 13 different cities, as well as a number of other service locations, including homeless shelters, domestic violence shelters, school-based health centers, and more. And with the geographic spread of the primary care clinics from the New York border to the Massachusetts border and the Rhode Island border, as well as a number of locations in the central part of the state, the organization's patients are interacting with at least 10 different hospitals on a regular basis, and each of them with different systems for how they manage and handle specialty care. The organization serves about 130,000 patients in those different sites. So most of the patients are racial and ethnic minorities, about 65%, and over 90% are at or below 200% of the federal poverty level, and nearly a quarter of the patients are uninsured, with about 60% being publicly insured with Medicaid, and that posed some unique challenges in terms of specialty access for these patients. When we started to experience the problem and started to hear the cry from our providers about the challenges in getting patients access to specialty care, we had a team of referral coordinators that started to share some of the challenges that they were experiencing in being able to get patients care. So this is an example of an email where the referral coordinators were letting us know that patients that needed orthopedics, couldn't get to certain places if they needed care anymore, dermatology, limits to patients that were only in certain geographic regions. We continue to have additional issues like that in this challenge for us. No longer accepting patients with this particular type of insurance. This is an example from ENT. Another one, we're no longer accepting the state's Medicaid patients for ophthalmology. So we just continue to have this onslaught of doors being closed to our patients. And this is our absolute ultimate favorite of all of them in terms of just understanding the supply-demand gaps. This was a letter that we got regarding GI coverage for Medicaid patients in our population, essentially that patients could only, regardless of the issue that patients had for GI issues, they could only be seen if they were born in certain months. And so that just really was one of the most profound challenges that we had. So we recognized there were a number of issues. Certainly the ones that Delphine already alluded to were really important, but that these were leading to a lot of downstream effects in terms of duplication, waste, and not just poor access, but disparities in health and very poorly coordinated care. Our patients were experiencing significant waits, and these really varied by specialty as well as by insurance or lack of insurance. And for patients that were able to access specialty care, ultimately the cost of doing so was in many cases prohibitive. So we identified a number of different barriers that came together that contributed to this problem in access, and not only was this extremely frustrating for providers that were trying to get patients access to specialty care, but it was very frustrating for patients. When we started to look at how we could solve this, we were fortunate enough to tap into the expertise of Alice and Delphine and the rest of their team and looked at this model as a way to potentially bridge these gaps that we'd identified. And we were focused in on one specialty to start off as we were considering developing a program. And the reason why we chose cardiology for our particular initial round was that we had a willing partner that was very interested and a specialty that we felt would be relatively amenable to an electronic consultation framework. So we started to dig deeper into our cardiology referrals over the past year and recognized that nearly 40% of the referrals that our providers had made to cardiology in that period were incomplete. And there was either because the patients couldn't get an appointment, we didn't have information on what happened, or this was not documented. And the wait time from when a referral was submitted by a primary care provider to when it was completed was over 50 days. So we decided to focus in on this as a specialty, and we're fortunate to receive funding from the Connecticut Health Foundation to do a study looking at electronic consultations in cardiology. So the way we set this model up was really, a little bit different than what we've heard at San Francisco General, just because this was a federally qualified health center, not really with any particular affiliation with an academic health center or a large hospital system. So we partnered with the University of Connecticut Department of Cardiology to serve as the specialty providers for this program, and decided to use a secure messaging system within the electronic health record, which is eClinicalWorks, giving our providers the ability to do essentially what was described by Delphine, attach clinically relevant parts of the patient's chart and send that information securely to a specialist in an external system that was not part of our EHR. And this was done through what's called a peer-to-peer P2P module that was an add-on in our electronic health record. What we aim to do is make this process really very, very minimally intrusive for the primary care provider, and had it reflect as much as possible the same amount of work that was being put into traditional referrals. We worked with UConn to make sure that we could get a response within a couple of business days, and also that if a face-to-face visit was required, that the patient would be able to be seen either at UConn or by a specialist of their choice if that was available. So this is a view of what sending a referral in eClinicalWorks looks like for our providers. So if they're sending a provider a referral, they would note their name, they would write a description of the reason for why they're sending the referral, and a diagnosis if one is possible. They are able to do one of two things. And so in our study, we ended up randomizing providers to two different groups. One group was able to send referrals through the traditional pathway, our control group, and the other group was able to send referrals through the P2P as an electronic consult. So if you look at the arrow, when a provider is sending a referral, the only difference really is that if in the traditional group, they would click where that arrow is and click on send referral when they were finished with adding all the information that was necessary. But if they were in the eConsult group, then they would click on where the circle is, where it says send instantly via ECW P2P, and that was the primary difference between the two. So on the front end, really doing the work and submitting the referral looked exactly the same. And then if there were the need to attach any additional documents like EKGs or reports, that was also a possibility in both of those groups. So as Delphine noted, there were a number of facilitators and barriers to being able to be successful in this work, and it really absolutely required engagement and excitement from a number of different stakeholders, including the leadership in the organization, but also the providers who were experiencing the troubles being able to get access to specialty care. We thought it was very, very important that the process that we created to do this did not increase or significantly increase the workload of the primary care providers, otherwise they would not use it. And we also felt that it was important to have somebody that was focused on coordinating the electronic consults that came in on the back end, similar to how we had a referral coordinator for the traditional referrals. Some of the barriers that we experienced were that even though it was a relatively similar process to the current referral model, there was some willingness, or some lack of willingness for some of our providers to change, even just adding on a different click in a different place or being trained in a new system. Also, just being able to communicate with the specialists who were not sharing the same electronic health record did require it sometimes that we'd have to send additional information that through attachments in that system. And although we were fortunate to have a grant that funded this work, the sustainable payment model was still absent at the time that we implemented it. So I'll turn it over to Nicole right now to talk a little bit about the actual results that we got from this, and we're going to skip over the flow because it's relatively similar to what Alice and Delphine reported.
Thank you, Wanda. So I just want to start by showing, talking about the reduction in face-to-face visits that we saw. So the providers who had access to eConsult sent about 200 or so referrals during the one-year intervention period, and about slightly over half of those were sent through the eConsult pathway. And we found that of the eConsults that were sent, just under 71% of them were able to be resolved without the recommendation for the patient to be seen face-to-face by a cardiologist in office. And just the implications for that on our end were absolutely huge. We also did a cost progression analysis of the wait time for the consult to be reviewed by a cardiologist. And I'm going to share mainly analysis 1, but I just want to first kind of let you guys know the difference. So in analysis 1, the kind of terminal event that we looked at was the date that the consult was reviewed by a cardiologist. So for the eConsult, that was the date that the cardiologist responded, and for the patients who had a traditional referral, it was the date that they were seen in office. Analysis 2 included patients who were recommended to have a face-to-face visit, and the date that they actually then followed up and got their face-to-face. So what we found was that the patients who had a provider in the intervention group were 1.5 times more likely to be seen by a cardiologist. And patients who actually got an eConsult were 3.5 times more likely to have their case reviewed. For patients who had an intervention provider but bypassed the eConsult system and were given a traditional referral, were no more likely to be seen by cardiologists than patients who had a provider in the control group. We also looked at wait times for the different groups of patients, and we're going to be looking just at the columns that are labeled A, but we found that patients who had an eConsult, their median time to visit with a cardiologist was 4 days versus 29 and 24 for patients who did not have an eConsult. Patients who had an eConsult were far more likely to be seen within 31 days of the referral being generated versus the other patients, and were far less likely to never be seen by a cardiologist. We also delved pretty deeply into the charts of all the patients who had cardiology referrals during the intervention period to look at what were the outcomes 6 months downstream. And across all the groups, we found no deaths, no MIs, no bypass surgeries, or anything major like that. What we did find was that patients who had an eConsult were significantly less likely to go to the ER with the cardiac-related symptoms versus patients who had a traditional referral. We found no difference between the groups in hospitalizations for cardiac-related symptoms. And I think this is a really, really important set of data because when you talk about eConsults and eReferrals to other people, the first concern that always comes up is quality. And it's, the response is, sure, this is a great way to improve access for our patients, but are we providing them with subpar care? And I think this shows very clearly that no, we're not. In fact, we're providing patients care that is as equal or potentially better. And that may be in part due to the fact that they're being seen much sooner than they would if they went through the traditional referral pathway. Finally, we did a set of surveys for our providers who had access to eConsults to get their perceptions of the process. Overall, we found that providers were satisfied with the eConsult process in general, and the one area that we had some dissatisfaction was with the documentation of the response. And I just want to point this out because it goes back to what we had talked about before about barriers to implementation and how when you have a piece of your process that the providers find is a little bit cumbersome, it really represents a burden. We asked how they would rate the quality of the content of the eConsult that they were getting, and across the board, all of our providers said that the quality was equal to or better than that of what they would receive from a traditional consult note that they got back from a specialist. Not surprisingly, they were all satisfied with the response time. And interestingly enough, before we implemented eConsults, all of the providers, or the majority, thought that eConsults, while it would be convenient for their patients and improve access, would represent a burden on them in terms of workload. But when we asked after they had been doing eConsults for 6 months, the majority of them actually said it had no impact on their workload. It did, however, was more convenient for them and was more convenient for their patients as well as improving their patients' access to care. So what's next? So our original study was a 1-year pilot looking at cardiology only, and unfortunately when our grant money ran out, we had to stop offering eConsults to our providers. But we were able to secure additional grant funding to set up a more sustainable infrastructure so that we could provide eConsults to all of our patients for multiple specialties. And we were working with not only our own providers, but providers from a large private practice in Connecticut and another community health center in Maine to do so. And our ultimate long-term goal is to develop a payment model so that we will be able to be reimbursed by insurers to provide e-consults for our patients. And that our reimbursement structure includes not only the cost of the specialty care, but also the infrastructure costs. So ultimately, this project will become sustainable beyond the life of any sort of grant funding. So with that, I will turn it over to Jeff, who's going to talk a little bit about what Brigham and Women's is doing in Boston.
All right, thank you very much. So I'm going to talk about our program at Brigham and Women's, which is in many ways still quite behind where UCSF is or San Francisco General is and the Community Health Centers project is. I'm going to sort of talk about how we got to, how we sort of looked at our referral program and worked on creating a medical neighborhood as a whole. So just some context, we're a 777-bed academic medical center in Boston, a teaching affiliate of Harvard Medical School. We have a physicians organization numbering around 1,600. They're all employed. The vast majority are employed, although that doesn't mean they're salaried and not very volume driven. About 1,400 or more of those are specialists. So we have about 160 PCPs. We are part of a parent organization called Partners Healthcare, which has over 6,000 physicians in it and 4 hospitals. We use a homegrown outpatient electronic medical record. We do not have an inpatient EMR, and we're implementing Epic in May of 2015, so about a year from now. I'll also say that we are located in a very risk-driven environment, so probably over half of our patients are in some kind of risk contract, at least those patients that are primary care docs in our system. But I will say, though we are at risk for them, the money we have at risk is relatively small, that we're still very much driven by fee-for-service, even though we're part of a pioneer ACO and in many commercial risk contracts as well. So we realized in the last couple of years that we have a big referral problem. We frankly have no system to facilitate referrals to our specialists, which results in many problems. Inequity and an unpredictable experience for providers and patients, minimal triage and poor access to our specialties, very inefficient workarounds, and leakage of referrals outside of our system. Point of this is not to read this slide. This is our attempt to draw a flow diagram for how to send a referral from one of our practices to a specialty. And it just goes to show how absurd our system was. We consider ourselves a referral center. We're a teaching affiliate of Harvard Medical School. 75 to 80% of our business is referral patients from, who do not have primary care docs at the Brigham. So it's pretty abominable that our system looked like this to get a patient simply referred from our own internal doc to a specialist. And the question we asked is, why couldn't it look like this, right? Very similar to what Alice has talked about. I'm a PCP. I contact a specialty. They call the patient. And if there's a question about that referral, can we engage in what we called at the time a pre-consult triage question with a dedicated specialist. So again, the biggest problems we had with our lack of a system was inefficiency. So our docs had to relearn a new process to send a referral to any number of specialties. Some wanted a fax, some wanted a phone call, some wanted emails. It really varied. The inequity, certainly among our physicians, those who'd been in the system for a long time, and therefore their patients were very good at navigating the system with their sort of homegrown connections, and others struggled. And then the lack of integration, and I'll show this I think on the next page, but a substantial number of our specialty visits occurred outside of our system. And this slide illustrates that. And I show this just in case it resonates with anyone. This got the attention of our leadership more than anything else. I mean, they were interested in the population health aspect of this, of trying to be more efficient and making it easier and improving access. But this got their attention more than anything else. So what this is patients with a Brigham and Women's PCP. This is the destination of referrals to the specialist listed on the bottom. So the way to read this is, if you look, on the right is for all office visits, all specialties in this time period. The blue is referrals that go to our own physicians. The red, peachy, refers to physicians who are in our sort of larger parent umbrella but outside of Brigham and Women's, and the green is outside the system altogether. So obviously from a integration standpoint, but also from a financial standpoint, we want our referrals to stay in the blue. So you can see that over 30% were quote-unquote leaking out. And this is just the minority of patients for whom we got claims data on. You need payer claims to be able to know when your patients actually leak. So we didn't know this for a long time until a few years ago, and this got the attention of leadership quite a bit to realize we have a problem with referrals, that we're not doing something right. So the goals were really twofold. As others have discussed, more appropriate referrals, so create an active system to ensure that the right patient sees the right provider in the right time frame, hopefully reduce unnecessary referrals and diagnostic tests, hopefully improve access, but also just quite simply standardize the process, create an easy way to get patients from a Brigham PCP to a specialty, and hopefully be able to extend that to a referral volume of patients who do not have a PCP in our system. So we looked at this as 3 paradigms for referrals. The first is really no triage needed. So I know I need a referral and I know which physician I want to refer to, great. The second is there's some triage, you need some help in at least picking the right doc. You either don't know or don't really care which physician the patient sees. And the last is I really need help. I'm not sure the right specialty or the right workup or the right timing. And as you'll hear, we did this differently from the San Francisco General model in that this is an opt-in program for us in terms of when physicians want that triage. We are not setting it up to review every referral that comes in. So this is just how we talk about referral management, the benefits that we see. So first, standardizing that process. Hopefully, by making the process of referring a patient to Brigham and Women's easier, we increase volume. Enable active triage, so what others have spoken about. So hopefully improve access, hopefully win in population management. And I'll just stop right there and say for those first 2 things, I think that's really important. You know, we are in this game of both still very fee-for-service driven, but also trying to succeed in the new paradigm of taking on more risk. And very few strategies that allow you to win under both of those paradigms. And I think this is one of them. If you can get referrals right, you get more volume. But if you can more actively manage them, you actually open up access and reduce unnecessary diagnostic workups and referrals. And I think it's just important to note that you can actually win no matter what paradigm you're in, or if you're like us and sort of one foot in 2 different canoes. The third thing, the sort of key component of referral management is tracking. So this is important. CRICO is our risk management foundation, our malpractice insurer. This is the key. You know, a lot of folks approach referrals from a safety standpoint, right? They want to make sure that, you know, if the patient is referred, they actually get an appointment and show up, and that the note gets sent back to the sending doc. You know, the whole safety component to them, I think, shouldn't be understated. It's very important to a lot of people for good reason. This is a huge source of lawsuits and medical liability. And it's also important, as many folks will know, for patients at a medical home certification through NCQA. And lastly, and not to be understated, is we want to be able to measure process and outcomes. And I'll show you some examples of data that we've generated, which I don't know if we'll be excited to those on the call. For us, it is exciting just because we were never, if you don't have a system to facilitate referrals, you can't actually measure what you're doing and who you're seeing and any process related to it. So we developed what we called Brigham and Women's Healthcare eReferral. It is a cloud-based referral portal allowing one-stop shopping for any Brigham ambulatory specialist. Similar to other models shown, referrals land in a work queue for each specialty. The specialty staff then calls patients to book appointments. And we worked very hard with each ambulatory specialty to ensure that they were willing and able to do that, because that was certainly a paradigm shift versus, you know, waiting for a phone call. The program is linked to an outpatient EMR, to our outpatient EMR, for patient identification and demographics and single sign-on. So we didn't get all the linkages we want for various political reasons. We were able to build it so that you use your Brigham username and password, and the system we built knows what patient you're talking about, but it doesn't have all the linkages we would like. This was co-developed with a company called Pareto, a startup vendor based around Boston that is focused on this area, and it was configured heavily for us. It was launched in January and ramped up over 2 months, and we're now fully operational for Brigham PCP sending to Brigham specialists. What we're calling Team Care is the module within eReferral that facilitates eConsults. So we did some pilot work with eConsults in years past, something similar to what others have talked about, enabling eConsults to be sent. I'm actually not going to focus on that. I'm more going to focus on how we implemented this tool. I thought it would just be sort of an interesting story. But implementing eConsults into our new eReferral platform is starting next month. So this is what it looks like. You can see it's custom designed for us. There's the corporate logo is not on there. It says Brigham and Women's Hospital on the upper left. This is the first page you see when you link to eReferral from our electronic medical record. So you can pick a specialty on the left, and if there is a subspecialty within it, you can pick that, and this was customized for us. Our specialties basically told us how many groups or subspecialties they wanted to see. When you send a referral, this is the work queue that specialties see, so they can, this is the list they work. You see made-up patient names, who they're referred to, who they're referred from. I can't emphasize enough how much of a workload change this was for our specialties, for their staff, really, not the specialists themselves, but for the staff to check this work queue, and they get notified when the work queue is available, and call the patients, schedule them, and then update this work queue. It's the same queue for folks that either sent a referral or are receiving it. It all gets updated simultaneously. I can log on and see the status of all my referrals, and the specialist can as well. And you can sort this by different docs or different urgencies or whatever you want. This is an example of some of the data we got out of this. So this is patient volume. The bars are number of patients sent per week. So you can see we started in early January in week 1 with a few practices, and by week 9 we were ramped up to all of our primary care practices. We're sending close to 1,000 patients per week. The line is how quickly specialty staff members call the patient. And again, this is something we would never have known about, but we can now track. And you can see that they're, on average, calling the patient, between 4 and 6 hours after they receive the referral. And I've had, several occasions where patients receive a call before they even leave my office. So it's just a sort of a testament to their willingness to roll up their sleeves and change their workflows. So one thing that was interesting, and this may be different from two of the more safety net institutions that spoke before me, we surveyed our docs before we rolled this out, and we said, do you prefer to refer to a specific specialist or just refer to the group? So do you like to tell your patients I'm referring you to Dr. Jones, or just you need to see a cardiologist? And over half said they preferred to pick a specific doc and tell their patients the name of a doc. In eReferral, they can do either one. Every specialty has a group option. You can just say, I want to see this, anyone in that, next available, or you can pick a specific doc. And what you can see is that almost 80% of the time, docs are picking the group, which is a big change for us, and I think reflects just the lack of a system we had before, and the fact that, the best way to get your patient seen quickly was to know somebody and say, I want you to see Dr. A. Now that anything goes, what we're seeing is that most of our docs don't care. They just want a competent specialist to see them and see them in short order. You can select the urgency of a referral, and on the bottom, you can see you can select urgent within 3 days, or within 1 week, or within 1 month, or I really don't have a preference, just whenever the patient wants to go in. There was some concern that physicians would overuse the urgent category in trying to get their patients seen, and what you can see in the pie graph on the left is that that's really not the case. Only 5% of the time do PCPs select urgent, and under 20% of the time less than 1 week. So really only a quarter of the time are they even saying the patient needs to be seen within 1 week at all. And on the right, you can see that our specialists are actually doing a pretty good job of trying to triage accordingly. This is the number of days to an appointment based on urgency. So the white bar on the left is when PCP selects urgent within 3 days, it's averaging about 5 days, including weekends. If they like a patient to be seen within 1 week, the blue bar, we're at about 11 or 12 days. So again, not hitting it exactly. We're still not where we want to be. And the green is 1 month, and we're averaging about 25 days. And then if it's, patient convenience, it's at 30 days. So what you're seeing is that the specialties are actually trying to triage appropriately. They're not quite hitting all the marks, but they're at least doing their best. And again, these are data that we didn't have before until we were able to measure it. All right, so team care. So team care, we're building within this module to be able to allow PCPs, at least to start, to be able to ask clinical questions of our specialists. And this will be, this is being built right now, sort of an adjustment to eReferral. So at the top, you can see you can pick either just send a referral or send a team care consult. And the work queue will be adjusted so that you can see referred to now says BWH Cardiology Team Care Support. So it's just really using the same work queue to get referrals and team care consults. So here's an example of a PCP asking a question, so 65-year-old chronic AFib, and wanted to, guidance around picking the best strategy. Is there an antiarrhythmic you suggest I start with, or should I just send them to you? And what this turns into is a sort of back and forth, and it's a bit hard to see, but you can see back and forth between Rima El-Shwari, who's our PCP in this case, and Callum McRae, who's our cardiologist, and they can really just go back and forth over the course of a day. And at any point, on the upper left, there's that drop down. At any point, the specialist can say, you know what, I need to request an appointment. This has sort of gotten too much for an eConsult. And at any point, the sending physician can complete it and say, thanks, I'm done. I don't need a referral, and this conversation is now effectively over, that I've gotten what I need. We've structured it, at least to start, so that the specialist can't close it. We don't want them closing it out and thinking that everything's fine when the PCP still has questions. So this goes live next month. We're again going to sort of do a soft rollout with 4 or 5 PCP practices, and we have 5 to 10 of our specialties participating, and we'll evaluate and go from there. And I didn't specifically talk about the funding. I'm happy to if people have questions. We are starting this with some internal funding. I will say it's interesting for our specialties, for our specialists. It is interesting in that the proceduralists, so we're doing this with orthopedics, with urology, with ENT. The proceduralists really don't bring up the money, and in fact don't even want it, because they know full well that this kind of program, if it weeds out a few of their patients who would never go to the operating room, they're going to do financially better because they will backfill, and they will just get more patients in and more likely to send someone to the OR. So if they can avoid patients who aren't going to be high revenue for them, you don't need to pay them to do that. On the other hand, our internal medicine specialties, who are quote-unquote more cognitive, or at least we'll say don't do a lot of procedures that rely on E&M visits for revenue, they naturally do expect to be paid, and we are working on a model to do that. And from what we've heard from some of the webinars we've been on and some of the sort of collaborative calls is that this is not an uncommon phenomenon we've seen around the country, that a lot of the proceduralist surgeons, don't feel they need to be paid for this, almost want to do it. But that's obviously not the case for more the cognitive subspecialties. So takeaways, referrals are a key inflection point in patient care. So it's a time when either the patient has a new diagnosis or there's some change in their symptoms or condition. I can't stress enough that optimizing and standardizing the referral process is a winning strategy, either in fee-for-service or accountable care. The technology is important, but the workflow is more important. So we couldn't have done this without a new eReferral module. In fact, we really started this wanting to do what Alice had done at San Francisco General, building this eConsult system, and realized we couldn't do it if we didn't have a basic referral management portal. So the technology is important, but I fully agree the workflow is more important, that you need people to roll up their sleeves and change how they do things, and that's harder to do and more important than the technology itself. And I'll also just say that the data really speaks. So the leakage data really is what moved the needle at Brigham and Women's. And I'll also say that the data we're getting out of the eReferral system is really having a profound effect and getting specialties, really interested in their process and their timing of how they handle referrals and their access. So I think everyone who does QI knows this, but this project has just made that, again, very clear of just how important having and showing good data is. So thanks. I think now we'll open it up to questions.
Thanks, Jeff, and I also want to thank all the other speakers for taking time to give us some insight on their work. I saw a couple questions come in, and I want to remind everyone that the slides and the recording will be posted on the CIN website. I got a couple questions about that, so do know that you'll be able to download this presentation as well as the slides for reference later on. So the first question that came in was during Delphine's presentation, and Gwen Hopkins asks if you can repeat or elaborate on the piece where providers who aren't integrated in the network being less satisfied with the effects of eReferral.
Sure. So here at the San Francisco Health Network, we have primary care providers, 4 primary care practices that are located on campus. We have 10 primary care practices that are part of the DPH network and share an integrated EMR. They're in the community, but share the EMR. And then we have a number of consortium clinics that are FQHC lookalikes that are across San Francisco and refer to our system here, but do not have a shared EMR. And what we found with our surveys was while everybody felt that eReferral improved clinical care for their patients, the satisfaction was much higher with those who felt integrated into the system, namely those who were co-located on campus or those who shared the electronic medical record. And that was compared to individuals who referred in but did not feel as integrated. So it really goes to show how important integration is within the network. And when we took those data to heart and tried to improve the eReferral system, improve the technology, improve the user interface and the workflows, and really enhance the specialty communication back and forth such that people that weren't physically on campus or weren't physically who did not have the shared EMR but still felt more integrated within the system, those satisfaction numbers went up for everybody. And so everything is a little bit better now, but yet still there is a discrepancy with those who are part of our formal network and are those who just refer in but are not part of the network.
Okay, great. Thank you. The next question came in during Wando's presentation, and Gwen asks again, you said this is a consult system, right? Wouldn't the expectation of a dialogue represent an increased workload / time commitment from providers despite streamlined initial submission process? Was there resistance about this?
So this is Nicole. I think I will take that one. I think that we left the providers the opportunity to have a back and forth dialogue with the specialists if they so chose. We did find that in very few cases did the primary care provider actually ever respond to what the specialist sent. So I think that's an indication that the back and forth did kind of present as a burden to them, and that they really just didn't take advantage of that function, and they used it more as a one-on-one direct, once and back, and that's it.
Okay. Great. And then there's another question here for you. Let me find it.
Actually, could we just weigh in on that for 1 second?
Sure.
This is Alice and Delphine. We were just commenting that the slide about PCPs initially thinking there would be a lot more work, and actually in the end feeling like it wasn't substantially contributing their workload. In our experience, it's different work So the PCP, instead of doing a lot of the clerical work of trying to track down where the referral went to, did the patient actually see them, trying to find the note, is actually engaged in clinical dialogue with the specialist, at least in our system where there is a lot of back and forth for some of the specialties. So just wanted to highlight that.
Okay, thank you. And then also, how did you, and this was going to Wando and Nicole, how did you receive payment/bill for consults not involving a visit?
So we received for the initial study a quarterly invoice from the health center that we paid a $25 per consult fee for each eConsult that they looked at. And as a health center, we took on that cost ourselves. And that was part of the reason that we weren't able to sustain the project beyond the grant. So we're exploring a few different potential payment options as we move forward with our new project. That we're probably looking at either creating a fee-for-service type of structure where the insurance companies will pay for this, but more likely it will look more like a global or a per member per month payment where they give us a lump sum to provide eConsults for their members, and then we deal directly with the specialist in paying them for their time.
Okay, thank you. So we have 2 more questions, and we're a little over time, so if people need to log off, do know this will be recorded, and you can check in again later. The 4th question came in during Jeff's presentation, and Evan asks, how do you staff your referral unit? Do you have a standard number of staff to support X number of referrals on the coordinating side?
It sounds like the question is referring to not necessarily eConsults, just referrals. This is done at the practice level, or sorry, at the specialty level. We do not have a massive central call center to do scheduling, so we're not that centralized. It's done at the specialty level, and we did not ask them to change their staffing at all. Rather, the people that would normally be answering the phones when patients or practices call are now spending a fair amount of time managing this work queue and reaching out to patients to schedule visits. I'll stop there if there's a follow-up question, or if I didn't answer that correctly, I'm happy to readdress it.
I'll jump in also. This is Alice, really briefly, that the person I'd probably also refer you to is down in LA, Paul Gibney, who's been leading their implementation there, and they actually have a centralized call center, and I believe it's on that. They've tracked many metrics, and I think roughly it's about 8 minutes per referral, but you'd have to talk to him specifically.
Okay, thank you both. And then the last question we'll take is from Condessa Curley. You spoke about the medical neighborhood. Do you include the local public health department as a specialty you could possibly use?
This is Alice, and I'll just say for our system, we actually do have components of the public health department, like our TB clinic, and we're talking about other parts, behavioral health, and potentially our STI clinics as part of the overall eReferral system.
Okay, great. Well, I guess we'll end here. Thank you again, everybody, for joining, and thank you to all the speakers today. If anyone has any additional questions or follow-up, feel free to reach out to me. And like I said, this will be posted on our website at www.chcf.org/California Improvement Network. Thank you all for joining. Bye.